Good morning. I'm Judy East, and I'm the chair of the Nevada County Council of Sierra College Foundation. I'd like to welcome you here today. A few logistics. Behind you are exits. There's an exit, there's one over there, and the restrooms are across the way over here. Before we start, we'd like to acknowledge the Nishanan tribe. With respect, we acknowledge the Nevada County campus of Sierra College as the traditional and unceded homelands of the Nishanan peoples. For countless generations, the Nishanan have carried out their responsibility as stewards of this place, originally known as Daspa. Sierra College commits to an ongoing relationship with the Nevada City Rancheria Nishanan tribe and their future generations who are an integral part of the Sierra College community. Give that back to Karen, thank you. So the foundation is an arm of the foundation in Rockland, and our purpose here is to support the students and the campus at Nevada County. To that end, we raise money and we give about $20,000 a year to the campus for programs. We will be having a fundraiser sometime in this next academic year, a night under Sierra stars, a stargazing fundraiser, so listen for that. Our money goes for a lot of projects, a lot of special events, and what we also do is we've established a program to help our students with scholarship essays. We found that 1,000 students started the scholarship application, but only 400 completed them. And what we realized is that the essay was pretty daunting. So we provide support for our students so that they can complete those essays and the application. With 10% of the Sierra College population, we get 25% of the scholarships. So we're very, very proud of that. In addition, in November, we're going to bring 3 of the 7th graders from the middle schools, the lowest SES middle schools, on campus for a day at Sierra so they can see how much fun it is and that there is a college in their backyard that they can go to. The other thing we're working on right now is the Alumni Association. So if anybody in here has ever attended Sierra College, you would qualify that, and we're planning a lot of activities. We have a sign-up sheet at the table at the door if you're interested in being involved. Additionally, we are looking for members of the community to be on our board. So if you're interested in that, I have a spreadsheet that I will put on the table. We'd like to welcome you here. If you haven't been on campus, please take some time to walk around and see what your tax dollars have provided for this community. Thank you so much.
Hi, everybody. Thanks for coming. Whoops, am I on? Can you hear me okay? We'll get the mic adjusted. We are recording today, and so as we turn to the audience piece, I'm going to want to make sure you have a mic. But before we do that, let me take a step back and just welcome you all to this segment of our Nevada County Forum. Our goal here is to talk about information that is important to this community and to all of us, and to give you some information that you may not know. And today I am really proud that we'll be talking about the state of rural health care, and joined by Dr. Scott Neeley. On March 6, 2022, Dr. Neeley became the president and CEO of Sierra Nevada Memorial Hospital. Previously, Dr. Neeley served as Vice President and Chief Medical Officer of St. Joseph's Medical Center in Stockton, and he was there for 9 years. A graduate of Harvard University, University of London, Stanford University School of Medicine, and the University of Massachusetts Amherst, Dr. Neeley is board certified in internal medicine, pulmonary diseases, critical care medicine, and hospice and palliative care. He's held several teaching appointments, including the University of Chicago, and has more than 30 years of experience as a practicing physician, educator, and healthcare executive. Help me welcome Dr. Neeley. So Scott and I are going to have a conversation, and this will go 40-ish minutes, and then I'm going to turn it over to all of you to let you ask your questions. And as we prepped for this, we kind of, so welcome, I guess I should say
Thank
that,
you.
right? I'll give you an
you.
opportunity to say a word.
Thank you for the invitation.
As we talked about this, what we decided to do is to segment our conversation into 3 areas. So we'll start just talking about the state of rural health care, and then we're going to spend the bulk of our time talking about why our hospital is different and in a different situation, and then end with talking about the future and what we can all do. So let's just start with the state of rural health care. We're all reading all kinds of scary headlines, like the fact that 30% of rural hospitals are at risk of closing. Some of us saw the situation or read about the situation in Madera, not that far from us, where the hospital closed. The county had to put $500,000 into saving it, and I think that's now happened, and the transition is taking place. But what's causing all of these challenges and problems to rural health care?
I think I would break it down into sort of 3 legs of the stool. There's the demand, there's the supply, and then there's how you pay for that. And folks who live in rural communities, the demand, have a number of unique problems that are somewhat different than folks who live in urban areas. There is typically, it obviously varies county by county and state by state, but there's typically an increased incidence of a number of issues that impact health outcomes in rural communities, an increased incidence of diabetes, an increased incidence of obesity, an increased incidence of some other chronic health problems that, for example, lead to an increased risk for stroke and cardiovascular disease. And there's, in many rural communities, also an increased incidence of substance abuse issues, which is the major cause for premature death in the United States now that the COVID pandemic is over. So greater distances to travel for health care and a unique set of healthcare demands forms one leg of the stool. On the supply side, healthcare is getting more expensive to do. Our technological abilities to help people has increased substantially, certainly during my own career, as have the efficacy of many of the medical treatments that we have. And they've all gotten more expensive along the way. And what that means is that there is a tendency to concentrate healthcare provision into more centralized areas where those very expensive treatments can perhaps be done more efficiently to larger numbers of folks, and it makes it difficult to financially support some of those types of treatment in areas where the population density is lower. And then finally, there's the payer side of all of this. And that is a very, very, very big chunk of it for every rural community. Essentially, it comes down to this. The majority of our patients, in fact, the vast majority of our patients, actually have health insurance that's funded by the government, either Medicare or Medi-Cal, for the rest of the country, Medicaid. And both of those payers, Medi-Cal and Medicaid, reimburse hospitals and healthcare providers at a rate that is below the cost of providing the care. Businesses don't work really well when they get reimbursed at a rate that is below their cost. And that is the issue for the majority of our patients in the hospital, and probably the majority of most patients who are being seen as outpatients. And so it's a very strange economy. It's a very challenging business model. While the impact of reimbursement below cost of providing care hits all medical providers, it hits a lot harder in rural counties. And that is why about 600 hospitals in the United States, almost all in rural communities, are at least at risk of closing.
So that's quite a trifecta, right? The problems are different and perhaps more expensive. The costs are higher just because you don't have scale, and you're not being reimbursed at a rate that works for you, or works for all of rural health care. So how, as you sit here in Sierra Nevada, how are we different and how are we the same?
Well, as far as the hospital goes, there's one principal difference that I think is important for us, and that is that we're basically a rather large rural hospital. As rural hospitals go, we're bigger than most. And that economy of size gives us a very minor advantage. But when we're talking about, really millimeters in terms of margin, that minor advantage allows us to be financially stable, relatively speaking, whereas perhaps a 15-bed hospital would not be able to handle it. I can tell you, for example, that productivity is one of our management metrics that we use to help to staff at the right level, and we have difficulty hitting our productivity targets when we fall below a census of 50, and we typically have a census of between 50 and 65. Today our census is 44. Well, our staff has to really manage in order to flex staffing down to a level where we can hit our productivity metrics. Our productivity metrics are a crucial management metric for us because salary and benefits is over 60% of our expenditure. It takes over 60% of our revenue. So appropriate management for any folks who do manage a business and productivity is really crucial around that census threshold. So you can imagine that a much smaller hospital, which still has many of the same fixed costs that we have, would have a much more difficult time managing with, say 15 patients as opposed to 55. That's the math.
And so today, our census is at 44. How often do you run under that 50?
10-15% of the time.
Okay. And maximum is, to just kind of set the stage for us?
72.
72.
And that's holding people in the ED and patients everywhere.
And so how often do you run near the maximum?
5% of the time.
Okay. Okay. And talk for a minute about how your staffing can flex. I mean, you mentioned that staffing is 60% of your costs. What kind of flex opportunities do you have as the census varies?
Well, within our labor agreements, we are able to have essentially minimum staffing that we always provide. And then as the number of patients go up, we can add staff, most importantly nurses. We add staff according to our staffing plan that we agree on as part of our labor relations.
And one of the things we've all read about, not necessarily with the dignity system, but other systems, is some of the challenges of staying fully staffed and actually getting nurses. Is that more of an issue in a rural community like this one, or since it's such a beautiful place to live, is that a piece of cake for you?
We have, real advantages living in Western Nevada County, and we have some challenges as well. It's true that there's a lot of people who want to live here, and so we're blessed with this environment, the great social construct that we have in Western Nevada County, and we do relatively well in terms of recruiting, although I think we have about 60 openings in the hospital right now. Nurse staffing in particular, but staffing for all of the licensed, or in other words, more highly trained positions in a hospital is challenging all over the country. We're not in any way unique are alone and being challenged in filling those positions. Probably an issue that is most prevalent in terms of unique challenges that we have is affordable housing. As a result of that, we have people who love working here, but who live in Roseville or Auburn. It's just challenging for folks to find, affordable housing that is adequate for their families in the primary service area of the hospital. And so, we're a mix of the issues that affect hospitals all over the country. In terms of the shortage of high skill level healthcare workers, including physicians. And, we have some advantages because of the, terrific lifestyle and the outdoors and the many cultural advantages that we have here. This isn't your run-of-the-mill rural community.
Right.
But, we have unique challenges as well.
So let's take a second and talk about doctor shortages and what the, I think we've all heard the stories of people who move here that have a hard time finding a doctor, or, in my own case, I ended up waiting on a list for 6 months, which is fine because I'm healthy, but before I could get a doctor. What can the hospital do about that? And given your education, your background in teaching, what are you doing to try to sort of help some of those physician shortages?
Just to sort of right-size the problem, California is expected to have a shortage of primary care physicians, just primary care physicians alone, of at least 4,000 by the year 2030.
Wow.
That's a big number. I would be happy with just one more up here right now. But let me also just say that we've got 2 new primary care physicians up here who are taking new patients.
Fantastic. Fantastic. So someone will be getting to you right after this to get contact information on how to do this.
It probably would be fine, but I think I'll refrain from saying their names on a video right now. But the Dignity Health Sierra Medical Foundation has 2 new primary care physicians who are taking new patients right now. So
and can you talk about
that's
the
a blessing
residency?
for us.
Yeah.
The principal tool that I have the most background in terms of increasing the number of physicians in a community actually is training physicians in the space. That was something I started doing when I was the chief medical officer and also the head of academic affairs for our hospital in Stockton, where we actually started 9 medical residency programs and currently have over 170 residents in training, including residents who are training in primary care specialties like internal medicine and family medicine. Fortunately for us, we have a very dynamic and just brilliant young physician here in Nevada County, Dr. Glenn Gukin, who had the same idea and started a rural family medicine residency program along with tremendous support from our Dignity Health Medical Center Foundation. We welcomed our first 2 family medicine residents into that program this year. Training physicians sort of in the space, place-based education is a tremendously powerful tool for growing a medical community. And it's powerful for a couple of reasons. Number one, when you're training doctors, you have the ability to recruit faculty who are a little bit different from the folks that you are typically recruiting when you're recruiting people who are principally going to simply be taking care of patients. And so we found that starting teaching programs allows us to recruit a slightly different type of doctor, somebody who's perhaps more interested in giving back to the community, certainly somebody who's more interested in giving back to our field of practice. And then, of course, there's the tremendous opportunity to retain the doctors that you teach. You teach people within your own culture, within your own sense of mission, and you have an ability to recruit them back to the community. And data shows that a majority of physicians will end up practicing within 50 miles of where they trained. And if you train physicians from your local area, in other words, if we focus on training Californians and train them here, that number goes up significantly. So if you take a medical student who grew up in California and then train them in a residency program in California, you have a very, very high probability of being able to retain that physician in your community.
That's great. I want to go back to the construct that you set up for us at the beginning about rural healthcare and kind of bring it home to our situation. And the first one that you talked about is how problems, healthcare-related problems, can be different in a rural community. We happen to live in the oldest or one of the oldest counties in California. We don't have some of the high income areas that some of those small counties have. And so poverty, I know, is an issue that's very near and dear to your heart. Can you talk about our county in particular from a healthcare perspective and how that might be different from the norm that you would that someone else in another rural county might be facing?
You know, I don't have data, and my friends in the audience know that I really like numbers. So when I say something, I like to speak with some level of surety and authority, and I don't have data to address that specific question.
Okay.
The factors that influence health outcomes, believe it or not, have mostly nothing to do with what I do, which is running a hospital. 80% of people's health outcomes, their health span, which is different from lifespan. Your health span is how long you are functional and living a meaningful life and able to take care of yourself, things that are important to many of us. Your health span is 80% dependent on things entirely outside of the medical care that you get. Some of it's genetic, but a lot of it is how you live. We probably have a really solid number of folks living up here who actually take things that impact their health span very seriously, Mm-hmm. I don't see that we have a particularly high prevalence of smoking. Substance abuse and excessive alcohol intake are big causes of shortened health span. Obesity, the food that you eat, whether you're active, those 5 things are the most powerful impacts on people's functional health span or lifespan. The education level, the sort of culture that we enjoy in Western Nevada County, may actually impact that, but I don't have hard numbers. But it's one of the things that I think about the most, because as we look at a health care system that is increasingly unaffordable, even for people who do make a good living wage, there's a lot of talk. There's a lot of talk in the in the talking headspace or the political headspace about lowering the cost of healthcare. I don't know how you do that. I mean, I know what drugs cost. I know what equipment for a medical center costs. I know what I have to pay in wages. I know what physicians demand from an earnings perspective. I don't really know how to make healthcare less expensive, at least, other than niggling around the edges a little bit. I think that the solution, if there is one, to the dynamic I've described, that sort of three-legged stool of unsustainability, has a lot to do with decreasing the demand. And that has a lot to do with how people live their lives. That's my personal view. We need to focus on health and making sure that everybody who has an opportunity to have a long functional health span has one. Really the model is, not just life expectancy. We can keep terribly ill people alive for a long time, but are they living? Are they living in a way that most of us would want to? The real focus has to be on helping people to live functional, healthy, meaningful lives for as long as possible, and hopefully decreasing the length of time at the end of their lives where they're very debilitated, and by the way, where they're spending an awful lot of money on health care that may or may not be benefiting them in a meaningful way.
And I want to use that as a key to give the hospital some great accolades. Going on right now is something that helps that happen with the Fall Prevention Clinic. I got a text this morning from a friend of mine who's there, who said there are 400 people at that particular event. And so, one of the things that makes our hospital different is all of the attention towards health and healthy living, and I do want to say thank you for that. And I will quickly take a right turn and get into the data, because I do know you like to talk about data. And the third thing that you mentioned initially was the reimbursement rates, and you talked about how most of us are on a government program of some kind. Talk about how funds come in to Sierra Nevada, and you sort of alluded to the fact that you lose money on some patients. Can you amplify that for us in our local situation?
Picture's worth 1,000 words, isn't it?
Perfect.
All right, so let's talk some numbers. Let's go to my first slide. This simply shows who is paying for the health care of our patients who are discharged from the hospital. And 59% of our patients who are discharged from the hospital, this is the last fiscal year, but I don't think it's changed very much. 59% of our patients are funded by Medicare. 23% are funded by Medi-Cal. So there you see that 82% number. 14% are commercially insured, and 4% are other. Those are mostly uninsured patients, or occasionally a workman's comp or something like that. So let me just make a general comment as a hospital president. 14% commercial patient payer mix is really low. And it's tough to survive on a 14% commercial payer mix. Healthy hospitals, really healthy hospitals, typically are north of 20% on that number. And in states that don't have Kaiser, they're typically north of 30%, because we live in Kaiser land where they suck all the oxygen out of the room. I mean, commercial payers. So that's where we start. But I think if you go to the next slide, you can see the impact of that. So this is something called contribution margin. And what contribution margin is the revenue that we see after variable costs are deducted. So variable costs are labor, supplies, medications, principally. There's a few other things in there, but labor, supplies, medications are variable costs. And the reason we call it contribution margin is that this is the amount left over after the variable costs incurred by taking care of the patient is available to contribute towards the fixed costs, right? And when we finally cover the fixed costs, then we might have some money left over. So contribution margin is a very important metric for healthcare finance. And what you can see here is that even though only 14% of our patients are commercially insured, the revenue that we get from those 14% constitutes 71% of the money that's left over towards fixed costs after the supplies, the labor, and so forth.
So let me say that a
spent.
little differently to be sure that I have it right. The 14% of the patients, after care is done, is funding essentially 71% of the hospital.
Yes. Okay. And you can see that our Medicare-funded patients, even though they constitute nearly 60% of our discharges, only account for 7% of our contribution margin. And then the Medi-Cal patients, kind of hang in there proportionally. That's an interesting thing that's a little bit unique about Sierra Nevada. We actually get better Medi-Cal reimbursement than many hospitals do, and that's due to our rural classification. So let me just take you to the next slide, which shows us the consequences of that formulation. And so this is essentially earnings after those fixed costs are deducted. And what that basically shows is that the only patients that actually generate revenue over expenses for the hospital are those 14% of our discharges that are commercially insured. We actually lose money, and that is net negative cash flow, that's cash out of pocket, on all patients who are government funded. On average, our patients who are funded by Medicare actually cost us almost $6,000 per discharge. That number is a little bit smaller with patients who are funded by Medi-Cal, but the bottom line is all of the positive cash flow that we have, money that's left after our expenses, comes from those 14% of patients who are commercially insured, and we lose money on all government-funded patients. And we're not unique. That is the story of healthcare in the United States. It's a very, very odd situation. Nobody who really takes a look at this can quite understand, why do we have this system, That's a long, long history lesson that I won't go into here. But, as I sit up here and tell you these facts, I'm not complaining. It's just the way it is.
And I want to give you a second to talk about, with this group, the piece of the conversation that you and I had about the benefit of us being part of the dignity system here, how that helps you keep some of your overhead low. You talked about IT and other things, and I've given you enough of a prompt now. I've probably taken your script.
You're reminding me about which conversation.
But can you talk a little bit about what our overhead looks like, and again, in relationship to some of these other rural healthcare systems?
Yeah, I was just going to say that when you look at the playbook right now for how to stay in business if you're a rural hospital, the number one step in that playbook is join a big health system. And there are a variety of reasons for that. Number one, our membership in Common Spirit Health and Dignity Health means that we take advantage of a vast amount of purchasing power. Common Spirit Health is the largest not-for-profit healthcare system in the United States. We're a $30 billion company in terms of revenue, and that means that we have vast purchasing power and that we can negotiate the very best prices when it comes to drugs, pacemakers, toilet paper, cleaning fluid, you name it. We benefit from the purchasing power of being part of a very large company. The other thing that we do as part of a very large company is that we have a lot of services provided that we would pay a lot more money for if we were doing them on a one-off basis. And you mentioned IT, that's a big one. because we have corporate IT that really takes care of our entire facility in terms of all of our IT and communication needs. Revenue cycle, which includes coding, billing, collections, registration, all of that is a corporate function, and again would be a lot more expensive for the hospital if we didn't have that advantage. So we get a tremendous amount of benefit from being part of a large company, and we also get a tremendous amount of benefit from being part of a not-for-profit that really has a mission of providing care and improving people's health. I've talked about this a little bit before. A couple of the articles that I've written touch on this. But, you know, the concept for us is not to have great financial performance necessarily. We have to keep the doors open. And hopefully we can succeed enough financially to have money left over to reinvest in capital. That's something you and I talked about, and that's an area where we're very challenged right now, but perhaps that can be another question. But you know, as part of a mission-driven organization, we don't have the purpose of pleasing shareholders. If you invest in the market, I do, you want your companies to be focused on maximizing their shareholders' profit. That's the purpose of you know, a for-profit company. Our purpose is to just keep going. And I mentioned a book that I am very influenced by, especially during the last year, called The Infinite Game, because The Infinite Game, a book by Simon Sinek, very succinctly defines the just cause, the overwhelming purpose of what we do. And the overwhelming purpose of what we do is to just keep going, just keep providing care, just keep serving people in our community. That's what we've got to do. Now, I've got to stay in the black. We have to stay in the black to keep the doors open, to keep providing that care, and to keep reinvesting. But you know, Common Spirit Health reinvests its profits in its facilities and in its people, and that's not something that you can necessarily say for a for-profit. And so I think we're very, very blessed to be part of an organization that really walks the talk and has the goal of providing health care and improving the health of everybody in our communities. So we benefit on the operational side for the reasons that I've described, but we also benefit because what we're attempting to do here, which is to take care of everybody who comes to us in need, is the mission of this organization.
And I want you to talk for just a second, because I am not managing the clock as well as I'd hoped. But so I'd like for you to talk just for a second about the structure, because yes, we have dignity, but we also have a community board and a foundation and a community structure. So can you talk about how all of that comes together in a way that looks different than a lot of rural hospitals are facing?
In 1 minute or less?
Please. No, I know it's complicated, but
yeah, the legal structure of a not-for-profit is pretty complicated, actually, and in fact, the legal structure of a not-for-profit hospital is that we're a registered 501c3. We're a charity, but unlike charities that completely depend on philanthropy, we actually need to make a profit in order to keep the lights on and to keep reinvesting. But we are a registered 501c3, and we are affiliated with Common Spirit Health. And again, Common Spirit Health is a not-for-profit with a very, very complicated corporate structure. But as an affiliate of Common Spirit Health, we are community governed. And what that means is the affiliation agreement has reserved powers that belong to our community-based board of directors. Most importantly, Those reserve powers include hiring and firing the CEO. So Common Spirit Health thinks that they're my boss, but Stephanie's really my boss. Or at least one of my bosses, okay? So that is one of the reserve powers of our board. The other set of powers that our board enjoys is financial oversight and the requirement that major financial decisions are reviewed and approved by the board of directors. Those are the most powerful strings that a governance system has, and so Sierra Nevada Memorial Hospital is one of a small number of hospitals in Common Spirit Health that actually have a fiduciary board. In other words, a board that is responsible for the finances, operations, and governance of the hospital.
And I think it's so important that people understand that, because it's not common in the dignity system, but it's not common in California either, in a lot of the rural communities. And it does really give us all a direct line to each other as you go about meeting the mission. Right. Of continuing to serve. One of the things that you said to me, Scott, that I was so impressed by is your goal as the CEO is not just to have the hospital survive, but thrive. Talk about that.
Part of continuing to do what we do requires reinvesting in our facility and in our community. The idea is not to just provide sick care. It's to help people live healthier lives. But, as part of that, we've got to figure out how to reinvest. When we were talking about hospital finances, what I said right now is, in many ways we're blessed because we're paying our bills and we're not in any immediate danger. But we're sort of like a homeowner who is getting by okay, enough money to pay the bills, enough money to pay the utilities, enough money maybe to go on vacation once a year and keep clothes on the kids. But we're one of those homeowners who might really be in trouble if the roof blew off, because we don't make that kind of money. And figuring that one out, I think, is a key part of long-term sustainability. Something that happens to rural hospitals that don't actually close is that sometimes they become critical access hospitals. In other words, they get a lot smaller. They have a lot less services, and they are taking care of people who aren't very sick, and if anybody is sick, they transfer out. It would break my heart for us to go in that direction, but we have to figure out a sustainability pathway if we are going to prevent that. And it's not any kind of a threat, it's just what happens when you don't continually reinvest in your facility. Well, if you're a homeowner and you're not reinvesting in the structure, you got to replace the siding once in a while. You got to take care of your gutters. You got to replace the HVAC once in a while. I'm thrilled right now because I get a $1.2 million new roof and helicopter pad this year. I'm not kidding. I am really happy about that. That helicopter pad is a vital part of what we do. And we need a new one, and we're getting it. But, how do we keep doing that? How do we grow services? How do we really be the kind of robust organization that survives into the future and continues to provide great care for the people in our county? I've told you, my number one platform is that, we're going to do it the old-fashioned way, which is we're going to have a really great product. And by that I mean, if you come to the hospital, you're safe. If you come to the hospital, you get very high-quality care. If you come to the hospital, we treat you with respect and dignity.
And
a
the-
really good product, and it's got to be delivered with love and respect for the community that we serve. And I think if we do that, that's the first step along that pathway of resiliency.
So I'm going to open it to the audience, to all of you, for questions in a second. But before I do, I want to ask one kind of follow-up on this thriving, this question about thriving. We all know the hospital's a good neighbor. We all know that you're a huge economic driver. To kind of look at the numbers, over 700 employees, millions and millions of dollars of economic benefit. And the
100
indirect.
million.
100 million, okay. Not then data, there we go with the data.
$100 million in salary and benefits that people get to spend in this community, and $33 million in direct community benefit that we fund.
So I was just going to say, the direct grants are just huge. What do you need from the community?
Well, in the short term, I need people to stop going down the hill to get care. And I'm not kidding. And, what I'm doing to try to make sure that that happens less is, as I said, providing an exceptional level of care and an exceptional experience to people who come to the hospital. But, I think that in a broader sense, I have tremendous partners in the community. It begins with our foundation. We haven't touched on that, but one of the reasons that we are such a well-equipped hospital and have such a great plant is that our community provides well over $1 million a year. I think we hit $2 million last year of direct support to the hospital for us to purchase needed equipment and renovations that we would simply not have the money for otherwise. So that community support is priceless to us and improves the level of care that we provide. I think in the long term, the committed leaders, the people who support us in the community, and our community governments, other important stakeholders need to engage with us in really thinking about what our vision is. Not for care right now, because you know what, it's pretty darn good. But what do we want to leave for the people who come after us? What do we want our legacy to be in terms of our ability to provide health care in the community? And I think a serious conversation about what that looks like, what it costs, how we might achieve that vision, that's the other thing that I want from the community.
That's great. All right, can we turn up the lights here for a second?
And turn those ones off.
Whoa. I feel like Carol Burnett. Let's turn up the lights. Okay, what questions do you all have? Yes, sir.
You mentioned something that is very important. You left it as a question. Oh, I'm sorry.
We're going to give you a mic just because we are recording here.
I'm referring back to your.
It's on.
To your question about how you could make costs lower, and it just seemed like it was a pervasive concern of yours. And I keep hearing stories about Canada and Europe and so forth, and how much less expensive medical care there is. We know about pharmaceuticals, especially in Canada, which is this country. Thank goodness our country is doing something about it now with the current administration. But can you give us an answer to that question? What do we need to do? Maybe we need to use the European model, for example?
That's a very challenging question for me to answer. I know the fundamental economics of how we deliver healthcare. And 60% of our revenue goes to salary and benefits. Almost all of the rest of it goes to supplies and fixed costs like keeping the lights on. I lived in England for 2 years, And the National Health Service is under siege right now and is not doing very well. Used to be kind of the crown jewel of British life. But, you know, you don't get from the National Health Service what people expect from health delivery in this country. They're more apt to tell you, well, I know you might like to stay on dialysis for 10 years, but we don't do that. In some advanced countries, you get 6 months of dialysis, and if you don't get a kidney transplant by that time, then you go on hospice. There are things that we do that cost a lot of money in this country that other advanced economies don't do. So part of it is the care that you actually get, and some of it is cost. Now, can we claw back labor costs? No, it's not likely to happen. Can we do something about pharmaceuticals? Yes. That's a real honest-to-goodness target. But probably more than anything else, if you think about the low-hanging fruit in healthcare these days, it's care that is being provided that is either extremely wasteful or is of very low value. And when you start that conversation, you get into ethics, you get into people's beliefs, you get into a lot of very emotional areas, and it's tough sledding.
Having said that, one of the things I'm going to ask to do is to go to the last slide, because one of the answers to that, and granted it's a smaller answer, but is to treat people based on their need. And urgent care was a big issue for us earlier with the close of Ubidox, and I want to give you a chance to talk about how the hospital responded, because certainly treating people...
Let's go to the next slide, please. Yeah, thanks.
It's here. Yeah, treating people in that way is far more efficient than having them end up in an ER.
So right place, right time, right level of care. Urgent care costs a lot less than emergency care, so that's a small area where you can make a difference. When Ubidox was forced to close, within a 2-week period of time, we were able to hire all of those providers and their office staff into the Dignity Health Medical Foundation. I'm really proud of that accomplishment. I don't run the medical foundation. They are my cousins. But I think they did a magnificent job of preserving those providers here in our community. And we now have a fully functional urgent care that is open. It's at 107 Margaret Lane. We're providing, I think, over 40 visits a day right now at the urgent care. We have same-day appointments. Walk-ins are seen, but we really encourage people to make appointments, and it's very easy to do so either through our phone number or through the InQuicker online-based scheduling application that we have. And my flyers have arrived. Is Sandy still here? Sandy had to go back to work. She brought the flyers over though. So I have some flyers and some cards there. It has a QR code on it. You can point your camera at the QR code and you'll go to our InQuicker app, which you can use to actually schedule a same-day visit at the urgent care. And so we have a few things left to do there. We're still working on getting our radiology, our X-ray capabilities fully up and running. That has to do with staffing and hiring, but we have some X-ray capabilities, and we have usually 2 providers a day, Monday through Saturday, and the hours are on that. flyer there.
So please do help spread the word on that too, because I don't feel like that's out yet. And it's really important for our community to know that urgent care is still out there and available. How about another question from the audience? Yes.
Speaking of the new urgent care and speaking of, speaking of the new urgent care and speaking of wanting to keep people from going downhill, the reason we can have urgent care there is because we don't have neurologists here anymore. And a lot of people are going downhill, many, because they can't get urologist care here. What can we do?
The softball questions are always the most fun, yeah?
Yeah.
It's a good question, though, because there are services that we're just going to have, we have holes in. So, yeah.
It's not a perfect analogy, but it is one that makes sense the more you look at the details of it. You also can't get cardiac surgery here. You can't have a lung removed. There are a number of advanced surgical procedures that you can't get done up here. I'd like to do them up here, but we don't have the volume to support it. And we actually didn't really have the volume to support that urologist. I can say, in all honesty, we offered to renew that physician's contract, and we could not come to an agreement on that. And he was not terribly busy. Now, the people who were seeing him really appreciated his care because he's a good doctor. But urology is one of those areas that's, I kind of alluded to at the beginning, it's becoming super, super specialized. Urologists who are busy and who are supporting themselves, unfortunately, this is still a business, they are doing a lot of surgery, and they're doing a lot of office-based procedures. And urology is an area that's kind of devolved into this, you're either basically in the office all the time with office-based work, or you're doing really, really sophisticated surgery that needs a robot. And if you have a robot, you have to have a whole bunch of people to support that robotic surgery program. And that's something that you really can't do anymore outside of a tertiary facility. So solving the urology problem is a really difficult challenge. We were blessed to have that physician up here for a few years. He was, a little bit farther along in his career. He wasn't interested in a robot. He had a unique practice style that allowed him to, be content with what he was doing up here. But to recruit a replacement for him is extraordinarily difficult. And I don't know if we're going to be able to, at least in the present time.
So I know we're coming up on time and there are more questions. I think Scott can stick around for an extra couple of minutes, but we like to end these forums just with a bit of a know your neighbor question, simply because we are all in a community where we run into each other, and I'm going to ask you a really easy one. So how do you spend your free time?
Well, I would say it boils down to basically three things. The first is my family. I've got a big spread out family. My wife and I prioritize spending time with them. My kids who are local are in Sonoma and Petaluma, and they are very, very precious to us. I really try to exercise every day, and I really enjoy that. Basically when I'm not doing one of those things, I'm usually reading. I love to learn. I just sit and suck up information all day and all night long if I have a chance. I'm kind of a boring guy, I guess.
Well, I don't know. One of my favorite questions is what's the best book you've read recently? So maybe I'll ask you to get that in real quick.
The best book that I've read recently, I mentioned Simon Sinek's book, The Infinite Game. The other best book that I've read recently is called The Myth of Normal. And it's by an author by the name of Gabor Mate. He's a physician. And he is well along in his career. He's written a number of books, and he's written some really wonderful things. He has spent his career principally in treating addiction, but he is also a really renowned authority on the impact of early adverse, what is it called? Trauma, essentially. Early adverse events, ACE. Early adverse events in childhood and the impact of trauma and stress on our health. And it's just, it's a tour de force of looking at people as whole human beings, you know. I'm not a big proponent of what is oftentimes referred to as the medical model. I was talking a little bit about how only 10 or 20% of our health outcomes really emanates from the disease treatment healthcare system that we have. You need that. It prolongs people's lives. It saves life. It's absolutely invaluable. It's the reason that we have the kind of life expectancy that we do in this country. But we need to look at human beings as whole people. We're remarkably complex. We're spiritual beings. We're people who have very complex consciousness, and the impact of that as we go through our lives on our health, on our quote-unquote physical health is profound. And so, that's kind of where my head is at right now.
That's great.
In terms of, living a healthy life and helping people live a healthy life. And I thought that was a really beautiful book.
It's always a good sign of how much people enjoy their jobs when their free time is spent reading about things that is very tangential to their career, right? Help me thank Scott Neeley.
Thank you.
And thank you all for coming. A couple of things before you get out of here. First of all, there is a sign-up sheet over there if you want to be part of our emailing list and you're not on it. Our next event will be October 20th, and we'll have a senior representative from the FAIR Plan here talking about how the FAIR Plan works and helping us, I guess, to learn about one of the larger insurers in the state of California now. When I was talking to him, they're writing 1,000 policies a day right now. So anyway, I'm excited about that. Please help me thank my fellow steering committee members, if you guys will raise your hand, for pulling this all together. And like I said, Dr. Neeley will be sticking around. Thank you for coming, and we'll see you in a month. Bye, everybody. Thank you.
Thank you.
That was great.